It is our duty as people who care for children across the health continuum to be able to watch and identify when we see concerning situations for abuse. We want to do this because it is an opportunity to identify where that protective barrier is around that child, that there is a lapse in that protective barrier. When we do report to CPS or to law enforcement or to both, it gives an opportunity to patch that protective barrier around that child and make sure that there really is a gap that's there. We can protect that child, we can protect other children that are in that circumstance, and we can affect change within inside of that home, maybe even get help for the person who is abusing that child. It's important across the whole spectrum of care around that child. I think the first and most important thing is to remember that you are our eyes, you're our ears, you're our nose out there in these homes. You know what's normal and you know what's not normal. And so when you identify something that's not normal, that falls off of that normal spectrum, coming in, telling us about what you're seeing, documenting what you're seeing, and even reporting yourself what you're seeing to the authorities allows an opportunity for change in that child's life. And what an amazing gift that we can give a child to be able to have a safe, protective environment. When you write down what you see, what you hear, what you smell, and what people actually say and the injuries that you see, it is in that child's record. And so other care providers can review it, CPS can review it, law enforcement, ultimately the DA reviews it, and that helps us to be able to match the injuries that we're seeing with the history that you're providing, or to be able to say, hey, wait a minute, there's some lapse in that protective barrier around that child, and what can we do to help fill that gap? When you call CPS, CPS goes out and first makes the decision whether they're going to go out and see the family and evaluate further, but they tend to do that for reports that we make on the healthcare continuum. And then when they go out, they're going to be able to identify and investigate a little bit further. Is there something that we need to do for this family? And then they get resources to be able to make sure that child is a safe environment. Sometimes that means things as simple as getting them a bed or making sure that they have food, or are going to school or to the doctor's office. Sometimes it's a much bigger thing, like making sure they're in a safe environment while the rest of the investigation goes on to make sure that child has a safe place to sleep, to eat, to be able to grow and become a member of our society. Thank you. Thank you, guys. Like you said, I'm Dr. Julia Magaña. I'm a pediatric emergency medicine physician at UC Davis, and I am also part of the child protection team. Our child protection team at UC Davis is available 365, 24/7, and so we are always available to our community and specifically to our hospital to ask questions and to do a little bit of a deeper dive on these kids that come in that have potentially been abused. Just so that you kind of get the context of how often we get called and what we get called on, we evaluate children that come in less than 18 that have been potentially mostly physical abuse, sometimes sexual abuse or neglect. And about a third of the time, it's clearly an accident. About a third of the time, we're like, oh, I don't know, maybe abuse, maybe not abuse. And we kind of work through that with our partners in the community, CPS and law enforcement. And about a third of the time, it is, yeah, that kid was hurt and we need to get them into a safe spot. So you kind of get a spectrum of what we're talking about. I have no disclosures today, and I do want to give you a bit of a trigger warning that this is hard stuff to talk about. This is hard stuff to think about. It really sucks. It really sucks to think about a child being hit, shaken, thrown, hurt in any way, shape, or form. It hurts our souls, and it should hurt our souls because that is not a normal adult response towards the vulnerable people in our community. And so this may bring up feelings, it may bring up memories in your own past. That's okay. Feel free to step out if you need to and come back and regroup. I hope that everybody can take away one or two little pieces that you can take back to your colleagues and that you feel a little bit more empowered to care for, to identify, to start thinking about child abuse in the kids that we see in our community, because this is important. What we're going to cover today is a little bit of everything. It's all going to be case-based, so Joe, I appreciate the questions at the end, but actually I would rather have questions throughout. I'm going to give you guys some cases. I want to hear from you how you would respond. Some of this, there's not always just right or wrong answers. It's okay if you don't know. Just tell me kind of what your thought process is and we can work through it together. We're going to look at cutaneous injuries, fractures, abusive head trauma, and then interpersonal violence, also previously known as domestic violence, and how that impacts our kids. We're going to look at human trafficking from the kid's standpoint, so that's called commercial sexual exploitation of children. And then we're going to get into documentation and reporting and what's your role and how can we do that well. If you have a phone, I have scattered some QR codes throughout this podcast, or throughout this talk. This is a QR code to a podcast that we did that is actually the story of a child that I saw at UC Davis, who's one of the nurses at UC Davis. It was their child. And it tells about how she wishes the people like us had identified abuse earlier, then maybe her kid wouldn't have 56 rib fractures. There were signs before. We could have prevented that moment. It could have been a different story. And this is her story and some of the resources for being able to identify that. So you can have this as a resource going forward and something that you can think about. But while you're scanning that, if you're interested, I want to ask you guys, what are the hardest parts about child abuse cases? What makes these challenging to talk about for you? You have children. Yes, absolutely. Maybe you don't have your own child, but you have a niece or a nephew or somebody else too. Seeing your own kids in that moment is really challenging. That is a hard part on our soul. Thank you. Anybody else? What else makes this hard?
I think there's the anger factor.
Yeah. Yeah, no, absolutely. Thank you for saying that, because that is absolutely true. It's really hard, and it's hard to stay objective in the moment of that, right? To be like, it's hard to think through, okay, A, B, C, D, E, I got to follow this protocol, I got to do all of this, when you have that anger, that's fostering in the back of your mind. And we're going to come back to that, because I think that's a really important piece to recognize and say out loud. Anything else? Yeah. 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 They can't be like, oh, I have 8 out of 10 pain on my left radius. That's worse when I extend and flex it, right? Like, they can't tell us. They are dependent upon us being like, I think that's not normal. Let's look into that a little bit more, right? And they can't tell you exactly what happened. For me, I think you're getting at the part that's really hard for me about these child abuse cases is like, I don't have a freaking crystal ball, right? Like, I can use evidence, and I work with law enforcement, I work with CPS, and I work with all of the people, all of the resources that I can get to be able to come up with a good answer. But I do not have a crystal ball. I do not have a way of knowing for sure what happened or how this happened. Even when somebody has been severely abused and it's clearly abuse, I still don't have a way to say like, oh yeah, they were hit with an iron 54 times, or that this is exactly how it happened or when it happened. And I don't have a way of saying who did it either. So these are really challenging cases. I just have the ability to say like, not normal, let's look into it more. And that's really frustrating for me. And I don't, not knowing who did it with that anger component of it, right? Like, you want to turn your anger towards the person that's in front of you. But when we look at the data at who's at bedside, who's actually presenting with these kids that are abused, it's actually not the perpetrator. The vast majority of times, the perpetrator is not sitting there right in front of you. And so that person that may be giving you a BS story, they might be giving you a BS story because they honestly don't know. They honestly didn't see it. They honestly have no idea of what's going on. And so they're giving you a BS story because they don't have anything to give you. And they weren't there. They weren't part of it. Anything else?
I think sometimes the time it takes to
Yes.
assess and determine when you're working in an EMS system where units need to run calls and get
Yeah.
available to take next calls and truly invest in the time needed to do an appropriate assessment.
Right, absolutely. Thank you, Dave. Like, not even just identifying it, right? Do you have the tools that you need to be able to make that confidently? And then how much time do you realistically have? And then how much time does it take to coordinate with CPS? God bless their souls, but they are not fast. They are not efficient. They do not work on an emergency continuum timetable like the rest of us do, right? And so that whole process can be daunting just to even think about it. Absolutely. Anything else? Another part that is hard for me is we know we have biases, guys. We know that we as medical providers, we as the continuum of people that protect these children, get stuck in our own heads. We have biases that are deep-seated inside of us, and we look at somebody and we tend to say, like, you're not reacting like I think you should react. You don't look like I think you should look. You have all of these other risk factors, and therefore, when I look through those goggles, I might see something a little bit differently than I would in another circumstance. And so we have to recognize those biases. We have to recognize that our backgrounds color the way that we look at these circumstances, and we have to be as objective as we can. And looking at these injuries and asking, I'm going to show you some of the questions that I ask as I'm looking at it, I hope will help you to be able to cut through, take off, or at least take out some of the shade of those biases, because we can't take it off completely. Anything else? Okay. So we look at child abuse and we look at childhood cancer. About every year, 1,900 children die from childhood cancers, and about every year, 1,500 to 1,600 children die from child abuse. So deaths are pretty similar. They're in the same realm, but kids that are impacted are much higher with child abuse than they are with childhood cancer. So these are both horrible things that happen to kids, and they happen at about the same frequency, but childhood cancer gets a lot more time in the limelight and a lot more funding. These are some of the kind of key questions that I ask myself as I'm doing an evaluation, and I just want to share them with you. Not that you have to be able to answer all of these questions in that moment in time, but this is kind of the thought process that we have when somebody comes in. I'm asking myself, is this history clear, vague, absent, or changing? And I'm not talking about like you have 10 seconds with that family to get a history and they give you one liner, and then it went from like, oh, it wasn't the table, the changing table, it was the kitchen table, like that, not that kind of like subtle type of stuff, but it's like the major stuff. Like I had a dad that came in, that mom came home from work and or from running an errand, and came home and found dad standing in the living room holding a seizing baby. And he said, oh, she slipped out of my hands in the bathtub. And he was in the bathtub and was giving her a bath for some reason. Mom couldn't quite figure out why. And then he came in, and we found, oh, there's a skull fracture and there's a head bleed. And he's like, oh, okay, it wasn't down inside of the bathtub. I was holding them up, like I was kneeling down and holding them up, okay? We got the skeletal survey back. We found a femur fracture and a radius fracture. And he's like, oh, no, I wasn't holding them here. I was holding them up to the water like Lion King. And you're like, okay, that's a pretty significant change in what we're talking about. Or there is no history and you see trauma signs and symptoms. And then basically what we're asking ourselves is, does that trauma history that they're describing match the injury that's here? And you're not going to have all of that information out in the field, but you guys do see a lot of injured kids. You do see a lot of kids that fall off of the monkey bars or roll off the bed or roll off the changing table. So you know what that spectrum of normal looks like. And if you see somebody that's seizing and has bruises all over their body and they fell off of the bed, you're like, I don't know. I've seen quite a few kids that have fallen off of beds. They're not all coming in seizing and bruised like this. Flag on the field. This is not normal, right? That's what you're asking yourselves. Was there a delay in seeking care in a child who has physiological compromise? I'm not talking about the kid that limped around for 2 days and the parents were like, I don't know, is that his normal weird toddler gait or is that something else? I'm talking about parents seeing their child seizing, turning blue, and putting them to bed, or going and getting a neighbor an hour later, or throwing water on the child. You know, we always, one of the PICU doctors always says, anytime there's water involved in the resuscitation of a child, I get worried about child abuse, right? It's like, it's a very weird response, and it's not a very specific measurement, but it is definitely comes out concerning when they're doing weird things. Anything that they can do to make this child normalize instead of having to take him into the hospital, that raises concerns. Is this child developmentally capable? If you have a 2-week-old who comes in and has a skull fracture and they're like, yeah, they're rolling around off the bed, you're like, I don't know about that. That doesn't make sense. And then are healing injuries identified? And that's not going to be for you guys. That's going to be for us. So we spend a lot of time looking for what we call sentinel injuries, or what are apparently minor injuries, things like bruises or subconjunctival hemorrhages, or even tiny little fractures that are healed and we're not going to do anything about it. But those are like the red flag that's sticking up that's saying like, hey, there is something big that's going on. And I use this iceberg picture to kind of illustrate that these little bruises, these little things that we see and we're going to go over today, obviously the bruise is going to go away. The kid's going to be fine. This injury is going to be fine. This broken bone is going to be fine. But that is the little piece of the whole puzzle that's there. That bruise that's not normal, that broken bone, that weird circumstance that you're seeing may represent a huge chunk of ice underneath of that water of that child's life that needs to be evaluated further, that needs more resources. And so we came up with this really great rule, okay? Oh man, that came out really small with that lighting here. But this is called the 10-4 rule, okay? It's an easy thing for you to remember when you're looking at bruises and asking yourself, is something normal or not? The entry point is child less than 4 years of age that has injuries, has bruises, cutaneous injuries, that did not occur in a public confirmed accident. So I'm not talking about the torso bruise from a car accident that you pick them up on scene, right? Like, or even a Walmart fall out of the cart type of injury. Like if you're picking them up at the scene and that matches it and they're like, yep, that's where it came from, okay, fine. Which, by the way, is part of why your documentation is so crucial, because you guys writing that down and identifying what the scene is looking like and making sure that that confirms with the story that the family is telling is a really important piece of what you guys do so that we can match that up later. I review your notes every single time. Every single child abuse case, I'm pulling up your sheet and looking at it and seeing what you guys are writing to make sure that it matches with what the family is saying, by the way. So, is the 10-4 is for a child less than 4 years of age that didn't happen in a public confirmed accident. You guys are public confirming people. And then we're going to say 10-4 faces to remember it. T stands for torso, and that is like where a little girl's one-piece bathing suit would be. So that includes the chest, the back, the buttocks. Does not include along the spine. Ears and neck, that's your 10. 4 stands for any bruise on a child that is 4 months of age or younger. They're just not able to get up enough energy to be able to crush that skin between two hard surfaces, break the blood vessels, and let the blood leak out into the skin underneath, right? They just don't have, the physics aren't there. They're not creating enough injury. We have this little phrase, those that don't cruise rarely bruise, and that's cruising is when you are able to pull up to a stand and walk along holding on to something. If you can't do that, you're not able to get enough energy up to bruise yourself. Okay, so that's the 4. And then the facies, P, stands for areas on the face. So F is for frenulum. That's the little soft tissue that attaches your tongue to the bottom of your mouth or your upper lip to your gum line and your lower lip to your gum line. If that's torn, that's concerning. A is the angle of the jaw. C is your fleshy cheek. Okay, not the zygomatic arch, not the top part of your cheek. That actually can be accidental bruises. And then E is eyelid, any of those inside, outside of the orbital rim here, anything deep inside there, E, eyelid. And then S is sclera, so the white part of your eye, if you see a subconjunctival hemorrhage or a scleral hemorrhage there, that's concerning. And then P is patterned. Now you notice it does not include your forehead, right? Kids are like lawn darts. Little kids are like lawn darts, right? They're going to land head first. And actually, in our toddler age, they're more likely to have a forehead bruise than they are to have a shin bruise. It's just that lawn dart physics. They're very top heavy. It does not also include over our accidental bony prominences, right? This is a picture taken randomly of my kids one day when my little one, my youngest one, was about 2 years of age, and then 4 years of age, and then 7 years of age. And while this is not a great picture, you can see a little bit here better on the screens. They're bruised, right? Like, my kids have bruises. This is part of life. Now, my youngest, who is not outside on monkey bars or riding her bike or learning how to do her scooter at 2, does not have as many bruises. She may have had a bruise on her forehead at that time, but she didn't have them in other spots. But my other boys clearly do in those front of the body kind of things, right? And if you think about where you fall, how you fall, and think about where your bruises are and where your kids' bruises are, you can start to identify what's normal, right? Think about your kids. Where do they have their bruises? Anybody that has kids want to share? Shins. Arms, right? Yeah, so across the elbow and the forearms is a kind of classic part. You think about how you fall, right? You're more likely to fall forward and you're to put your arms out. So this anterior, if we think about our body in planes, this anterior plane is far and away our most likely spot to get it. Now, weirdly, we land on our butts and we land on our hands fairly frequently, but we don't get bruises in those spots. And we just think that the body is that way. It's the vessels within inside of the hands and the tushy are less likely to actually break with force, and because of the fat cells that are there, we don't get bruises on our hands and our butt. But everything else falling forward, that's kind of where it is. Now, anytime I see bruises that start to cross planes, you know, if this is one plane of your body, this is another, and then you've got microplanes on your face there, any bruise that crosses planes, that's a little bit weird also, right? Like, why are you bruised on one side and then flipping over to the other side unless the object's wrapped around your body, right? So I like this picture because it's legs. Both, you said bruises on the legs. Yeah, you're right. Bruises on the legs are the most common spot. But on the right-hand side here, you see what normal bruises look like. And on the left-hand side, I think we can all say not normal, right? What about it is not normal? It's on the back of the legs, right? Like, we're more likely to fall. Now, it's not to say you can't have an occasional bruise on the back of your leg, right? Because you can. Your legs are out there doing stuff. What else about it?
Back of the joint is a weird spot.
Yeah, right. Okay, so you're talking about a really protected area, right? Okay, I might expect one on my calf, maybe even on the back of my leg, a little bit weird, but not impossible. But in that joint, in that popliteal fossa in the knee is a little bit weird.
One leg's bruised more than the other.
And one leg's more than the other. And if you look at this, it's a little hard to tell on this screen, but that is what we call, the official term is a freak ton of bruises, right? Like, that is too numerous to count. I can't even count how many bruises are on there. That is not normal. Anytime we go into double digits of bruises, it's like, I don't know, that's just a little bit weird. Not impossible, you know. My middle child probably has double-digit bruises on occasion, but it's not an everyday thing, right? It's not something that we see on a regular basis. Even families that are like, oh my God, my kid's bruised all the time, it's actually pretty rare to meet double digits for the number of bruises that you have. That is a lot. What else about that one is weird? Anybody able to see anything? Yes. Preach it. Yes, that is right. Bruises, even if we fall on a diagonal, even if we fall on like a star-shaped object, it doesn't usually leave a pattern. And so patterned bruises in and of themselves are concerning for child abuse. And this is actually somebody's been struck with an object. And actually you can see looping on this one. If you get a little bit closer, you can see the top of a loop that's there. All right, so that's it. That is the key thing that I want you guys to get out of today. 10-4 faces P, okay? 4-year-old, any child less than 4 years of age that's not in a public confirmed accident, that's where we need you to come in, and that has bruises in the 10-4 region, torso, ear, neck, child less than equal or less than 4 months of age, anywhere on their body, okay? Faces is on your face. F is frenulum. A is angle of the jaw. C is fleshy cheek, not the zygomatic arch, not up here, not the bony part. E is eyelids. S is sclera, the white part of the eye. And then P is pattern, just like what we were talking about. All right, so let's go over some cases. This is a 4-year-old that was picked up from daycare. He said at preschool he tripped and fell. What do you guys think? Yes, no, maybe so? No, why no? Pinch, pull, yeah, absolutely. Yeah, so wrestling maybe, right? Although very rare even with wrestling with brothers. The other thing is look, it's both sides, guys, right? What did he do? Like, donk, donk, you know? Anytime we have more than one plate involved, we have to like step back and ask ourselves what's going on. But you're right, these are wrestling, punching, pulling injuries. This is cuffing, hitting, pinching, and they are not normal bruises in a child. Now, not to say a kid can't have an ear bruise, right? They can. I've seen them. They're accidental. Like, they can absolutely happen. They just don't happen on a regular basis. So when we see them, it's that flag on the field. Wait a minute, what? Let's get some more history. Let's find out some more information. Let's dig a little bit deeper. It's not to say that it equals abuse. It's just to say, like, hey, we need to think about it. Now, this 4-year-old picked up from preschool or daycare, that one probably needs some serious evaluation because either he was around kids and not observed well enough and there's some neglect of the supervisional neglect at that school, or there is some adult that is not treating these kids well and is pinching, pulling, cuffing like you were talking about, Joe. Ear bruises are not normal. They're not common. They're worth an evaluation. We just had a kiddo the other day that came in that was 6 months old that has bilateral bruises around the ears and significant swelling around the scalp that they woke up and said something fell into the pack and play. What do you think? Yes, no, maybe so? No, yeah, we said flag on the field. We need to look into this. We need to look into this more. Okay, this is a case, this isn't her actual picture. All of these cases, by the way, have been changed a little bit that are not specific to the particular ones, but are have been changed enough so that the parts stay true, but hopefully we can't figure out who these kids are. This was a kiddo that I had during residency. She came in the middle of the night to the emergency department via EMS. Mom and grandma lived together. I had every social risk factor under the book. You walk into the house and you're like, ah, shoot, this house is not a good place. There's a lot of bad stuff that's going on. But grandma was called EMS in the middle of the night because she had been called by mom who was screaming in the room. She was co-sleeping with her 4-month-old, and her long hair had wrapped around the baby's neck and had left these marks and kind of essentially strangulated this baby. Grandma ran in, cut off the hair, called EMS. They brought him into the hospital, noted these marks that are there around the neck. What do you think? Yes, no, maybe so? No, no. We said the same thing too. We were like, wow, that is a super weird story, highly concerning, because it's that neck part, right, guys? We don't bruise. And what?
Did you find any hair? Because the possibility of getting all the hair off.
Right, good question. We did not see any hair. But we did ask people to go out and look for hair. So she got a head CT, she actually got a neck CT, she got a skeletal survey, she got admitted to the hospital so that we could pull in all of our resources. That's what this bruising rule is supposed to do, is just to be like, hey, I'm not saying this is absolutely abuse, but I am saying we need somebody to go look for hair, right? Like, if this is true, there should be evidence at the scene. So CPS went out to the scene, and they actually brought in this big knot of hair from the trash can that had been there. We measured it. We measured mom's hair, matched the hair up, tried it around the baby's neck. We did everything, and sure enough, it matched. Now, I did lose quite a bit of stomach lining on that case, wondering, when is that baby going to bounce back? Because this seems like a wild, wild story to me. But she did go back into the home. I think CPS got involved for some of the other stuff, the other chaos that was in the baby's life. But not to say that it is abuse, but it is weird, does need further evaluation. Okay, this kiddo comes in, he was coming in for a physical, had a little bit of cough. Provider pulled up the back, pulled up the shirt and noticed these bruises on the back. They have no idea. He wrestles with his brother. What do you think? Yes, no, maybe so? Maybe? Yes, absolutely, yeah. And in fact, in our study, I enrolled kids in this 10-4 Faces P study in San Diego. Along that spine is where we saw accidental bruises, and in fact, I think I saw a couple of them that were wrestling with their brother that had bruises along the spine. But this is a lot of bruises, right? Like, this is double-digit bruises across the back. Definitely needed a CPS report, and they needed to go out to the home to evaluate further. This is concerning bruises. All right, this kiddo comes in vomiting, no story, and you notice these bruises across the belly. Concerning, not concerning? But it looks like a bike, right? Or almost like a car accident, right? Like, it's got that kind of like, I've got a seatbelt sign across my belly, right? Yeah. It's a small child to be on a bike, right? Yeah, they're not going to be out there. That's why that 4-year-old cutoff for the 10-4 Faces is because after 4, like, all bets are off. They're out in the world, right?
And it looks, the one on the top looks maybe older.
Yes.
It's kind of yellowing a little bit.
Yeah. So we can't date bruises. I cannot go to court and I cannot tell you how old a bruise is. There's just too many variables that go into it. But we can be like, oh yeah, various stages of healing, potentially. And I agree with you. That top one looks like that's got yellow in it, so it's probably at least 72 hours old. So torso bruises, highly concerning. Your belly is soft, guys. Even y'all in fire that have washboard abs, your muscles do not create enough force to be able to provide a hard source for the forces on the front of your abdomen to crush the tissue and leave bruises. It's just not a common spot. It's too soft and squishy. Now, across your pelvis, yeah, sure, okay, right? But on your actual belly itself, it's very unusual. And this is highly concerning, especially with no bruise story, and needs a CT abdomen and pelvis, head, and skeletal survey. They need like the full workup. All right, potty training says this is a rash. It's not. You can't feel it. You can't feel anything. What do you think? Concerning, not concerning? It looks like a pinch. That's right, Joe. Yeah, so this is a pinch mark to the tip of the penis and is very concerning. Even though, like I said, we land on our tushies, the genitals themselves actually very rarely bruise to almost never. Now, you can have a straddle injury. That can happen. And, again, is there other things that support that concept? But a bruise in the genital area, in the underwear area, is concerning. This is actually very rarely sexual abuse. This is still more likely physical abuse, and often comes around toilet learning times, and people punishing or trying to leave a memory of why you should not have an accident. All right, this kiddo came home from dad's house. Mom picks him up, and there's a rash on the tushy. Concerning, not concerning? Concerning. Why is it concerning? It's a weird location for it, right? Like, why is it up top there? If you've had kids, the wet stuff goes down to the bottom. Gravity doesn't take it there. You don't have to touch that to know that that is not a normal spot for a diaper rash. So this is spanking injury. That railroad track on either side is classic for spanking injuries, and that's where we leave it. All right, this is a kid that's in foster care, transferred from one foster care to the other, foster parent to another, and they notice these bruises on their backside. Concerning, not concerning? On the leg there? Yeah? Yeah, the location. We have a baby, and we have the location that's concerning, right? Those are, we already said 10-4. But this actually is not a bruise. This is what we used to call Mongolian spots, and now we call congenital melanocytosis, meaning that you just have extra melanin inside of underneath of the skin. Kids that have more pigmentation, that have darker skin, are more likely to see it, and it's kind of like a tree. It goes along the center, over the sacrum on the backside is the most classic part for it, and then it can go up over the back, and then around the ankles and the wrists occasionally, although less frequently there. It's more right across the back, like up a tree across your back there. And that's going to be really hard to be able to differentiate when there's lots of care providers. Most of the time you're going to see it and the family's going to be like, oh yeah, that's been there since birth. And then you'll be like, okay, that's fine. But we get these in the hospital, mostly concerns when it's been switched between care providers. And I just want you to know that that is out there and that is a very normal thing. Two of my 3 have had it. This is just a picture to illustrate that one-piece bathing suit area. These are the space that we want to be concerned about with bruises up onto the chest as well. Okay, this little love bug came in with bruises on her face. No story. Yeah, slap mark, right? So this is pattern. This is what you were talking about with pattern bruises. That's concerning. Anytime you can see the outline or recognize the implement, that is a problem. Flag on the field. Slap marks leave a negative imprint that's there. Anybody recognize that? That is a loop mark that people use ropes, belts, anything, any implement that can be folded in half and then struck, and then the top part of it moves the fastest, and so that's why you see that kind of U shape that's there, because that's the part that strikes and leaves a mark. Pattern bruises are not normal. Those are concerning. Those should be taken seriously. Anybody see anything concerning on this baby? Yeah.
I just had a question about this.
Oh yeah, please.
It looked like they're showing someone grabbing like a thumb in that last picture. Like, is that someone's hand on there or what?
Yeah, their hand is holding the leg down there.
Toddlers, like, you know, you grab them by the arm or something.
Oh yeah.
And
Mm-hmm.
they're freaking out. And
Yeah.
whatever.
Yeah.
There's some bruises and stuff like thrashing around. You ever presented with a case of like good parents, good family, just rare circumstance that you know they came in for a leg injury, but now you see this bruise and you're like, that's weird, but
Yeah.
nothing else lines up.
Yeah, absolutely. We're presented with those.
CPS, but he had like 3 arm breaks in 4 months or something, like something ridiculous.
Mhm.
But it was just he was a crazy clumsy kid.
Yeah.
But his parents had to go through this whole.
Absolutely. Absolutely. And I think that you're getting at a really important piece here of like, what are the risks of reporting, right? I don't have that glass ball. I mean, I just don't. And so I can't be perfect, but I can say like, hey, you know what? We looked at 2,000 kids across the US, and it's really unusual, less than 4 years of age, to have a bruise on the belly that's there. Let's look into this a little bit further. It doesn't mean that it's abuse. We have to be really careful because we can overstate what's actually there. It just means that like, hey, we need to look into this a little bit further. And if we do a skeletal survey and CPS talks to the family, and it's like you said, good family, everything, like the protective barriers around this child are there in place, and we can't find something, then they just get like, they get dropped. Multiple fractures like that to me, if that was my case, I'd probably be like, hey, let's just make sure these bones are healthy. Let's do a bone workup because we need to make sure we're not missing something medically here.
One of them, this is my friend, one of them was a spiral fracture.
Yeah.
It was the last one, like someone twisted his arm.
Yeah. But spiral fractures happen.
He jumped up a set of stairs is what happened.
Yeah, absolutely. And let's get back to that fracture story, because that is one of my points actually for later on. But yeah, I am not a benign intervention at UC Davis, right? Like, calling me I am not just like giving somebody a glass of apple juice, right? I am pretty intense with my history. I try to make it as comfortable for those families, but like, me being involved is very stressful for families, right? And understandably so. Like, think about yourself on the flip side of that. Somebody coming in and asking all of the questions that I ask and going into as much detail as I go into feels invasive, right? So, and then that much more for CPS, as much as I try to be a comfortable, safe spot to have these discussions, just the fact that you're calling CPS feels really huge to these people. So we want to be as evidence-based as we can. We don't want to overstate what we are seeing and what we're doing. And we want to be as objective as we can. And we need to make sure that those biases that we all intrinsically have inside of us are not coloring how we report and who we report and when we report. So it is not a benign intervention. CPS is getting better. There has been a massive shift, even in my career. When I first started off, CPS was aligned with law enforcement, and they went in with a law enforcement policy and approach and interrogation. They have now separated themselves as a cultural shift and now go in much more like what we were saying before about like, what can I do to help this family? What resources do I need? I had a kiddo that, I remember the mom more than the kiddo, but she, a couple of months ago, I saw a family and mom said, somebody called CPS and they got me resources and changed my life. I now am drug-free. I have taken parenting classes. They are, like the kid came in with an injury and we were trying to figure out when it had happened. She's like, I go to these parenting classes, but I can see my kiddo and they provide care for them. I now have a home to stay in. Like, she was like, my life is on a completely different trajectory because they came in and helped me in my life, I had another kiddo that there was like 3 or 4 family members sleeping in one room that they shared with, you know the home that I'm talking about, right? The kiddo was on an air mattress that the whole family was sleeping on, and the older 12-year-old sister was supposed to watch 2 kids that were sleeping on this air mattress, and she, one of them was about to flip off backwards, and so one of them was sitting on the edge and the other one was about to flip off the air mattress, and so the teenager jumped to grab the one that was about to fall, and you can guess on an air mattress what happened to the 6-month-old that was sitting. They did a Cirque du Soleil flip and landed on their backside onto this concrete floor and then had intracranial hemorrhage and fractures and all of this type of stuff. And, we had to do the whole thing. We had to get CPS involved, and we had to get law enforcement involved, and we had a head CT and a skeletal survey, and it was a big thing. But then in the end, when we figured out with sister what happened with Cirque du Soleil jump off of the air mattress, CPS then, when I discharged the kid, we called CPS. They drove and met the family at their home with a crib. So they had a bed for the baby to sleep in and now had a safe environment. And that's like what they're trying to do. That's who they're trying to be. And then sometimes it means bigger stuff because we need to protect the child or we need time to figure it out. But that's what they're trying to do. That's who they're trying to be. All right, this baby came in with not eating, poor eating. Anybody see anything? It's really subtle. Yeah, that upper lip is swollen up there on the right-hand side of the baby's face. And when we opened up, we could see that there was a torn frenulum underneath of the tongue. So that little tiny piece of flesh is really well protected, right? Because it's deep inside of your mouth. You've got a lot of protective barriers around it. It actually, while it's a teeny tiny piece of flesh, it actually fairly rarely breaks, especially underneath of the tongue. On the upper lip and the lower lip, it can break, right? If you fall and your face goes like this, it can lift up that upper lip and tear it. That's the most common one. But in our little infants who are not creating enough energy to take that upper lip and rip it up, do not tear their frenulums, and that is a worthwhile evaluation. These can tear when they're inflicted by somebody either hitting them across their face or by stuffing a binky, a bottle, a spoon in their mouth. Shut up, stop crying, eat your food, and they slam it inside there and it rips that frenulum. And so those are something that we watch for and take seriously. Now, again, it's not diagnostic. I have 3 kids and I've had 3 torn frenulums, 2 of them in the same child. Again, my middle child. And my husband likes to remind me that they've all happened on my watch, not on his watch. It's fair because they have all happened on my watch. So they do happen, right? Like it can occur. We just have to have a reason. We have to know what's going on. We have to take a look at it. This is a torn frenulum in an older child. This one was probably accidental. Once they have teeth that look like that, they're probably able to create enough energy themselves to fall down and tear that. All right, so those same principles, while studied with bruises, can also be generally used with burns. So this kiddo came in and mom said, oh, he was running and he sat on top of the iron. What do you think? Yes, no, maybe so? No, yeah. Why no?
We sat on it,
Like,
sat on it again.
yeah. How do you do that, right? Yeah, maybe, yeah. So this is a protected area. He should have clothes on, theoretically, right? Most likely he would have clothes on when he sat on them. Even with burns, there may be patterns like you can see a line, but you can't usually see the outline of the implement that they were burned with. You can't tell exactly what it is the majority of the time. Also, that is a large surface area to have created that kind of pattern with, at least one time, as you're saying. So this is a highly concerning bruise. It's patterned. It's in a protected area. And also this child looks like he's old enough that he should be able to give us some stories. Anybody recognize that pattern bruise? Or burn, excuse me? Yeah, that's the end of a lighter. That's also patterned and is not accidental. Those are inflicted injuries. Okay. Yeah, that's a tough one to see. This is a baby that came in with bruises and fussiness and after being picked up from dad's house. Anybody recognize that pattern? Yeah, those are bite marks. So when an adult is at the spot where they're rolling over and biting a baby, they're in just a whole different brain space. And so that has actually a fairly high mortality associated with it. Same with burns. If you're like waiting for something to heat up and then burning a child, your brain is in a whole different pathological spot and you need resources, and that is like high mortality rate. And the same is true with bites. They're just like, it's just not something that's usually done out of anger, right? It's not a normal adult response. Now, it might be a normal 3-year-old or 4-year-old response, right? My kids have been bitten that Davis Diamond standing in line with another kid. They felt like they should be in line in front of them. They turned around and bit my son on the arm. Again, my middle child. But they turned around and bit him on the arm. And it's like, it can happen. And I will say it is very hard for us to be able to differentiate between a child bite and an adult bite. We can measure and we photograph and we do all of these things, but in the end, it's really hard to differentiate between that. But this would be a highly, highly concerning situation. This child clearly needs a different environment to be protected in. All right, this kiddo came in during my fellowship in San Diego, came in with vomiting and diarrhea. Anybody recognize anything there on that baby? There's a little cheek bruise on this 3-month-old, right below the right eye there. So, kiddo less than 4 months of age, bruise anywhere on their body is concerning. Now, when we see a child that comes in with vomiting alone, we need to think, in less than 2 years of age, we need to think about inflicted injury, abusive head trauma. And this team, even though there was diarrhea there, they saw the bruise on there, they said, flag on the field, Doesn't mean it's abuse, but we need to figure out something more. And they got a head CT, and they found this. This is bilateral subdural hemorrhages. See that white kind of W on the back of the head? That's blood that's sitting on top of the brain. That is highly concerning, and in this case was diagnostic for abusive head trauma. Abusive head trauma is the term that we use now. We used to call it shaken baby syndrome. We don't anymore because there's more dynamics to how this is inflicted than just shaking. But the shaking is a common component of it. I'm going to show you a video here in a second that will kind of show you the dynamics of how these injuries occur. But it's repetitive acceleration, deceleration injuries. So you've seen those people that have been ejected from the car, right, and have that diffuse axonal injury, that acceleration, deceleration that hurts their brain. Well, with these babies, it's over and over and over and over again. And so you're going to see those same kind of injuries that you see with severe acceleration, deceleration injuries, but in kids. And they're going to be in most commonly less than 2 years of age. It can happen older than that, but it happens most commonly less than 2 years of age because they don't have strong neck muscles. It's the most frustrating time for parents, other than teenagerhood, I hear, and they have really big heads in proportion to the rest of their body. Remember, those lawn darts, those heads come into play here again. And, yeah, absolutely. Right. Actually, you bring up a really good point. Like, you can't, it's harder to lift up a 4-year-old and physically shake them to get their hands around their chest, all of that type of stuff. So, right, their dynamics of their body changes. These kids can present with vomiting, high-pitched cries, and seizures out of proportion, okay? If you have a kid that's seizing that fell off of a changing table, it's like, that's pretty weird. That's an unusual circumstance. Definitely needs to be evaluated further, especially for us. We are going to take that more seriously. And it's the #1 cause of morbidity and mortality in our kids less than 1 year of age. So, warning, this video that I'm going to show you here is tough to see. Let me see if I can get it to play. I'll try it over here. This is an example of a baby that is being shaken, and you can kind of see, like you're saying, about how people typically grab around the chest, and that's part of why bruises in the torso are concerning, and why we see rib fractures, because they're squeezing and grabbing around the chest. And then the head is moving backwards and forwards, and babies' brains have a higher water content, so they're shaking more like this, and those cells are shaking, and the blood vessels that you just see here are breaking, they're tearing as they're being stretched. And so you get blood that's released on top of the brain. And then in the back of the eye, because the blood vessels in the eye have also been stretched back and forth, we don't know the dynamics inside of the eye as much. We'll get retinal hemorrhages. That's not for you guys to have to worry about, that's ours. But this is why your kiddos are going to come in much sicker, are more likely to need airway, more likely to be seizing, is because the neurons inside of the brain themselves are stretched and stretched and stretched. And that stretching impacts them, and then your RAS system, which is your breathing system, is actually stretched and injured as well. And so these kids are more likely to be apneic, more likely to need airway interventions with minor trauma. This is the RAS section right here that you're seeing. This portion of your brain that tells your body to breathe is impacted disproportionately, and so these kids are more likely to come in much sicker than you would expect for the proportion of injury. And that's showing how it impacts your breathing. It actually physically stops, it impacts the nerves that help your lungs to expand and breathe. Thoughts, questions on that? Okay. This is something that you guys definitely run into as well. This is a 6-week-old that we saw at UC Davis a couple of years ago that came in brought in EMS, responded to the scene. The parents were fighting. The neighbor had called the police. You guys, everybody showed up, and the baby looked okay to EMS at that time. They advised mom to take him in. They said baby hadn't been hurt or impacted. EMS did an exam. Everything was okay. Mom went over to her sister's house, and then her sister said, I think you should take him into the hospital. He's really fussy. He's crying too loud. He's not acting normally. I think you should just take him in. Mom takes him in and says, oh yeah, I mean, he's a spitty baby, but he's maybe spitting up a little bit more than normal. And maybe I was yelling too loud. That's what it was. And then it was like, when they pressed him further, she was like, well, maybe when Dad was hitting me from behind, I leaned forward and I may have squished him. They watched the baby eat in the hospital. He didn't spit up. They sent him home. Mom went home. She then left to connect with Dad again and left the baby with Auntie, who said, oh, UC Davis said the baby was okay, said everything was fine, and she hadn't had babies before. And so about 3 days later, she FaceTimes another auntie, and it's like, I don't know, he keeps doing this. It's really weird. I don't know what to make of this. And so she FaceTimes while he's doing that, and the other auntie's like, that's a seizure. You need to take him into the hospital. And so she called 911. Mom asked her not to. Auntie called 911 anyways and came in, and the baby had abusive head trauma all over there, really severe. Had been seizing for 3 days. Because each of us in that continuum of that child's care, we at UC Davis, we did this. You know, there was multiple providers that saw this kid and said, I don't know, it's hard, right? Like, there's not a crystal ball. Like, the baby had a normal exam. It's so hard to tell. These are the challenges of these cases, right? It's really, really hard to tell. But when we have a kid that has been exposed to interpersonal violence, it is child abuse. It is not a normal thing for a child to be exposed to these things. It also puts them at risk for child physical abuse, all of the abuses, emotional neglect, all of those things. And so law enforcement does should cross-report to CPS whenever they respond to these scenes, and CPS should be involved. CPS, by the way, we called CPS too, and we asked them to respond, and they said, go ahead and send Mom home. We'll see them there. So it was like everybody and their mother, well, except for my mother. Everybody and their mother got passed through this child and sent them on home. We try to take these very seriously. I think the vast majority should be brought in for an evaluation, should be checked out, and if they come in to UC Davis, we're probably going to do a skeletal survey in these young infants, a good skin exam, and watch them for a little while, because it is a risk for these kiddos. But at a minimum, they should have a CPS referral. Now, if family absolutely refuses, says no, then it's going to be up to CPS to make that call, because we don't have enough evidence to say you have to come in at all costs. Like, we have enough to say a judge should bring you in. But I think that the vast majority of them deserve a good physical exam, deserve observation, and deserve a physician to lay hands on them. It's not perfect, but it's something else that we can do to protect these kids. Yes.
Can we explore that just a bit? We've had calls to base stations from crews in the field.
Yes.
Seen by providers in the field who are uncomfortable with the parents to saying that they don't want to have their child transported.
Yes.
Usually we'll put a resident, a third-year resident or an attending on the phone, and we don't have eyes on.
Yeah.
You have eyes on the patient, and you're uncomfortable with releasing. We're going to agree with you. In other words, that's your assessment, and you're uncomfortable with releasing. And although the parents want to, they want to sign that release at scene, they want to sign an AMA. They don't want to go to the hospital. You don't have to have them. They're not. They cannot force an AMA on you if your assessment doesn't fit that picture. So yes, get us involved. We'll confirm your assessment. Maybe speak with families. The provider puts a person on the phone, family member. But if you're uncomfortable, and we've seen this, if you're uncomfortable with releasing that scene, then don't.
Yeah, I agree. If you're the ones, you are our eyes, you're our ears, you're our nose, you are the ones that are there for us. So we are dependent upon you. If something feels uncomfortable to you, that's fine. Most of the calls that I have gotten have been like Yeah, the kid had a febrile seizure. They look really great now. They've had febrile seizures before, and they're running around and playing. I can't get them to stay on the gurney for me. Most of the calls that I've had have been like that, and you're like, I don't know. I think that they probably are going to go to urgent care or something. Like, that's fine. That's a different circumstance, right? If it's this kid is like not acting normally and I feel uncomfortable with how they look and parents are leaving AMA, then yeah, you should go with your instincts.
If you show up at my house and try and take my kid, right, I'm going to be pissed.
Yeah.
Even if as a good parent.
Yeah.
So this is like a significant thing if you're talking about, hey, I know you don't want the kid to go, but we're taking him.
Yeah, it's huge, right?
Cops involved, and
I agree.
I can't just take him. I'm going to have to use police there.
You would absolutely.
So it's going to be very significant.
It would have to be a significant thing, which is why I would say, like, you have to be really sure. Yeah, and if you just want to like kind of cover yourself because, the parents, your protocol says take a child that had seized and they're running around now and look good. That does not rise to that level by any stretch of the imagination. And I think that we have to think about that. Like, what if I was the parent that's on that side? How would I want this approach? What would I want to hear? How do I communicate where my concerns are? Because they might not be an educated parent, right? Like, they may not know that noise is not normal, that is not just them snoring. So, educate, inform, address where their concerns are. Why is it that you don't want to go into the hospital? What are you worried about? And sometimes it's fair, right? They're like, oh, well, I don't have insurance. This is going to knock me out of my knees, or I have already have an appointment with the PCP today. I just want to go to the primary care doctor and not take my kid into this COVID-drenched hospital, right? Like, I mean, we've seen a lot of those types of things. So I think understanding where their concerns are, addressing, educating, and working together. But like, ultimately, you guys are our eyes and ears for that child's assessment. We can help to share that and problem solve.
Yeah, and the only other comment and follow-up I have is that, we're a teaching institution, so we'll have residents on the phone, and one of the things that Dr. Rose, our base hospital physician, works with the residents to help them understand is that we're not there to give medical advice to families over the phone, to tell them what to do happens if there's another seizure at home, whatnot. We're there to help provide and reassure them that, yeah, maybe your child should be seen, or you have a good plan to go see the doctor in the office this afternoon at 2:30, or you're going to go down to urgent care. We really work towards having the residents not give medical advice over the phone. We are not there. Again, you are our eyes and our ears. If they have a good plan to go to a doctor,
yeah,
and the story fits, and they got an appointment at 2:30, then by all means, then that's a good plan. But if they have no plan and you're really uncomfortable, we're not going to fill that gap and give medical advice from a base station perspective to make it okay to leave the scene or that type of thing.
Right. It's more of like a problem-solving tool, I think. That's what I think of it as. Correct me if I'm wrong. Okay, so next case here, going back to your friend with the spiral fracture. This is a 3-year-old that I saw during fellowship that went camping with grandparents, came home, they could just kind of like threw their stuff out, their gear into the middle of the living room. Parents were working during that time. They were back in another office. The 2 younger kids, this was a 4-year-old boy, 3.5, 4-year-old boy that was jumping on the couch. He jumped off of the couch. Sister said he landed on the toys and then fell to the ground and cried. Parents came out, checked him over, didn't really notice anything, and they put him on the couch and put on a Disney movie, so that he could just like kind of feel better. Went back to working, came back out, and we're like, he hasn't gotten off of the couch. That's super weird. And they then transported him to the hospital, where they found this spiral fracture. Okay, so it's not 2 views, so you can't tell definitively, but you can see that it starts at the top of the femur and then works its way down towards the knee. And they were eventually transferred over to our children's hospital for surgical correction. What do you think? Yes, no, maybe so?
Very high velocity.
It's high velocity. Takes a lot to break a femur.
Story fits though, right?
Story fits. Maybe, right? It's like it's a maybe. Yeah. Yeah. So this was a real story, and the story did match it. So what you guys are thinking about is the biomechanics of a fracture, right? That's what I spend a lot of time thinking about, is the biomechanics of something. How do the dynamics of that fall fit into the body? And so spiral fractures happen from one portion of the body being pinned down or held down, and the other part twisting around it. And it does take a fair amount of force. Like, the femur is our strongest bone in our body. But it does break, and it can happen, and it does happen. And once a kid gets moving, for me, it's out of diapers is what I think about it, but it's really after the age of 3 is where it really starts to drop off of being inflicted. Once a kid gets moving and they're jumping off of, what was your friend jumping off of? What was it? Set of stairs, right? I've seen him jumping off of off of a porch or off of stairs or off of a bed or whatever. Once they get moving and are able to climb, the vast majority of them are actually going to be accidental. And it's because their foot stays down and the rest of their body moves around it. Now, conversely, how does this get inflicted? Well, in our youngest children, especially ones that are in diapers, they're laying down on a bed typically, and somebody grabs the leg, and you know what babies do. You know what 9-month-olds do when you're trying to change them, right? Whenever there's good loose poop, that's when they really got to get wheeling and moving, because they got to get out of it. And so they start moving. Somebody grabs the leg, twists it, holds it. Stop moving, stop kicking. You kicked me on purpose. And they grab that leg and they twist it and they pull it, and the hips are what's holding it down, and the leg is what's twisting around it. So that's how it gets inflicted. Also, with the abusive head trauma, we see spiral fractures because somebody grabs by a leg and twists and shakes like this. So that's why they're so concerning, right? But it's especially in those kids that are not mobile, that are still in diapers. And I add diapers because spiral fractures in a 12-year-old that has developmental delay and cerebral palsy and is still in diapers and isn't getting up enough energy to create a spiral fracture themselves could still be concerning as well. It's really about what is that developmental capability of that child. Okay, here's another one. This is a kiddo, this is a 6-month-old that came in with leg swelling. Mom took care of the baby most of the night. Dad took over at about 4 a.m., fussy crying baby. Finally came in and laid down with mom, and then they slept till like noon, I think because they'd been up all night with their baby. And mom woke up at noon and noticed that he was doing this, where he's got 3 extremities moving and not the 4th. And noticed that his leg was swollen and took him into the hospital, where they identified this is a transverse mid-shaft femur fracture that is angulated and non-displaced. What do you think? Concerning, not concerning? Concerning, right? You don't have a trauma history. You have a femur fracture in a non-mobile child. This is like quintessential concerning. But it's not so much like this is a transverse fracture. So transverse fractures can happen from forces along the bone that cause it to crack, or it can also happen when there's a fulcrum point that's on that long bone and then it pushes in and out. So in this particular case, this was probably somebody's hand on their knee and their thumb and the mid shaft and pulling like this, either shaking or just grabbing the leg, and that thumb became that focal point where there's a transverse fracture that's there. This is highly concerning. This is child abuse until proven otherwise. This is it. This is a very, very concerning situation, because even if this baby doesn't have blood on top of their brain, they probably will in the future. This needs a modified protective circle around this baby, clearly, full stop. Just needs to be taken care of. All right, this is some stats about child abuse. About 90% of our abusive fractures, our inflicted fractures, occur in kids less than 5 years of age. Okay, so once you're on your bike, your scooter, you're out there on your skateboard, it's gonna happen a lot less frequently, right? About 50% of our fractures in kids less than 1 year of age, 50, are inflicted fractures. That is massive. There are very few things in medicine, guys, right, that are 50%. Like, that just doesn't happen. So if you see a fracture in a child less than 1 year of age, you need to think about abuse. But by the time you move up to 3 years of age, about 30% of those are inflicted. So that's still quite a fair amount that you should be like, let's stop and think about this. But it drops off. It drops off. As you get older, the older you are, once you start getting mobile, then you're more likely to have your own forces, your own mechanisms that create your fractures. So the concerning fractures that we get worried about are in those that are non-mobile, like we talked about. We see classic metaphyseal lesions, which are little fractures that you guys aren't going to run into, but those are highly concerning. And Joe hears about them in our sessions. And then any rib fractures, or anytime we have multiple fractures or fractures of differing ages. Probably that's kind of what got your friend into the system, right? Is they have multiple fractures and of varying different ages. And this is why we do lots of x-rays. Because remember, who said that the kid wasn't mobile or couldn't talk to us, right? Like, they can't tell us I have right elbow pain. I may have a little tiny subtle fracture there. This is why we have to do a skeletal survey, which is 21 x-rays at the hospital. And we're just looking for fractures everywhere because we have a high chance of finding them. And the kid can't tell us about what's going on and what hurts. So there's lots and lots and lots of x-rays. Okay, this was a case that I heard about not that long ago. And we were, as child abuse doctors, we were kind of asking, what is the role of EMS? So I would love to hear your guys' thoughts on this. So it was an EMS team that was called for a 54-year-old with chest pain. They walk in, it's like one of those mobile homes, and they walk by another room where the 54-year-old is not, and they look in and they see a clearly adult in bed, undressed, with clearly a young teenager-y, not sure how old they are, but looks way too young to be in that circumstance. They're both sleeping in the bed. They go back and take care of the 54-year-old with chest pain. What is your obligation to what you saw when you're walking down that hallway? Police?
Police involvement.
What do you guys think? Anybody else? What would you do? Would you go ask them? Would you check on her? Would you just take care of the 54-year-old and call police? I'm genuinely asking. We were like, as child abuse doctors, we were like, the team did nothing, by the way. Somebody felt bad about it afterwards.
But
Talk?
Yeah.
start talking to people on scene,
Yeah. Just ask, right? Like, I mean, like, maybe, I'm trying to think of a scenario where that's okay, but, you know, like, maybe there's something else that's going on. You know, if you don't have a whole lot of beds, I don't know.
They were sleeping?
They were sleeping, yeah.
Well, EMS was walking through their...
I mean, I don't know. That's what they said. I don't know how you do that, but yeah. Pretending to sleep. Maybe they're on drugs. Maybe they got some opiates to help them. Some sleeping aids there.
I feel like I'd rather have an uncomfortable conversation then
Yeah.
and get ahead of it.
Yeah.
And find out later.
Yeah.
By the process of activating, you know, law enforcement will come out if we request them, but
Yeah.
simple question.
Yeah.
To people in that house.
Yeah. Yeah. I think that uncomfortable, they felt uncomfortable afterwards and brought it up with the team afterwards, and it kind of like sparked that discussion. Dave, what are your thoughts?
Yeah, so you know, obviously, extended families live with each other, you know.
Yeah.
And you know, let's say a low, you know, a challenged socioeconomic kind of a status, you know,
Right.
grandma, grandpa, grandfather, you know, cousins. It could be very completely innocent, but I think it's worth the question.
Yeah.
So who are all these other people here? And
Yeah.
I walk by the other room, and you know, and it may be a general question where there's a simple answer.
Yeah.
You know, they're in town visiting and whatnot.
Yeah.
Yeah, I think that, you know, the setting and being careful of our own bias.
Yeah.
Towards, you know, I'm not having any of my cousins stay at my house, by the way. It's not happening. But it could happen. And it could be easily explained, or it could be worth a separate conversation.
Yeah.
Sounds
Brian,
like a chief
Joe.
officer call. What do you think?
Yeah.
How do you escalate that within the department?
Yeah. What do you guys think, Brian?
The adult was naked?
Yeah. They don't know. He's under the sheets, right? Like he doesn't have a shirt on, so.
Encourage the conversation.
Encourage the. Like, what words would you use? Like, give us some tools to like, what do you say in those moments? Mm-hmm.
Who are they? How are they related?
Mhm.
What's the situation going on?
Mm-hmm. Yeah. What's the situation? Yeah.
Yeah, I would ask, I mean, you could even ask the patient, you know, like, hey, what's going on with the
Yeah.
patients here?
Yeah.
And just be like, who else lives in the house?
Yeah.
And then after that, I would open up, how old is that girl?
Yeah.
And then who's that laying next to her?
Yeah, yeah, that's good. That's how I approach a lot of these circumstances, is just like, I'm setting the scene. I am here for, this is something that I always ask my patients, blah, 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 blah. This is something I always do as part of scene safety or whatever, you know, like this is what I always do. And then let them explain and then get more specific and kind of like narrow in on where your concerns are that are
I
there.
think you simply you holler at the door, and if it's a guy that gets out and he's just wearing sweats and no shirt, like a lot of people sleep without a shirt.
Yeah, exactly, right? Like, I mean, they don't know.
You gotta put some clothes on, then you have a lot more stake in the
You feel
game where you're like-
more reassured.
Yeah, you're like, okay.
Yeah.
Can anyone think of a situation where a naked adult should be in bed?
Yeah.
With a child, family member or not?
Right.
No.
No, right, exactly, yeah. And that this team just walked by and then they felt bad about it afterwards. This is something that we're talking a lot about.
I think
Yeah.
it's in a perspective of asking that kid, or depending on how old they are.
Yeah, teenager,
And,
yeah.
You know, on an EMS call, right, the captain's getting demographic information or whatever else. It's a perfect opportunity as we're treating the patient. And I don't know what the crew dynamics were on this, but
Yeah.
for the captain to go over and, can you check what's going on in there?
Yeah.
That's a little weird. And the captain's going to do captain stuff and figure it out and upgrade it or downgrade it or whatever. And, I mean,
Yeah, I love it. I think that's
we
great.
absolutely have to talk to that person that's in that bed. I mean, right, there's some sort of red flags here, right?
Yeah.
Something making the hair on your neck stick up. We're gonna address it immediately. You have
Right.
to-
I love it. I mean, that's what this 10-4
What's
facey
going on
stuff
with the
does
kid? The kid
too,
goes,
right?
I don't want to be here right now.
Yeah,
Okay, well,
let's modify this
nobody know
situation.
that if we talk to 'em, so.
Yeah. I mean, that's what all of this is, right? None of this stuff is like 100%, well, most of it is not 100% diagnostic of child abuse. It's saying like, whoop, hair on the back of my neck is standing up. This is concerning. And we just want to kind of educate the hairs on the back of your neck as to when to stand up, right?
You ever run a call at a naturalist commune?
No.
I'm uncomfortable the entire time.
Yeah.
And I'm uncomfortable with that child or that person standing next to that adult with it all hanging out. But
Interesting.
that is my bias.
Yeah. Yeah.
It doesn't happen all the time, but I've definitely had it happen to me where I walk in and everybody's naked and you're kind of like, ooh,
Yeah.
what's going on?
Yeah.
We have one of those in our jurisdiction.
Yeah.
Yes, we do.
Yeah.
When I worked at 59, uncomfortable.
We have
Yeah.
retired captains who were naturalist lifestyle, and they were not weird, and they didn't do any weird stuff, and they had their kids involved in it, and it was.
Yeah.
But-
Super interesting.
But I find it really weird when I walk in and like everybody's naked.
Yeah. Yeah.
I'm not comfortable with this situation.
Yeah. Yeah, my sister is actually, I'm surprised I made it this far into the talk without claiming my street cred, but my sister is a clinical supervisor in Santa Rosa, a paramedic supervisor, and she has some pretty wild stories that often do not involve clothing and various substances that just make my skin crawl as well. But what we want to do is we want to educate those hairs on the back of your neck to be able to, when is this normal, when is this not normal, and then also to empower you to know that you do not have to figure that out. You do not have to be the one that says it was Mrs. White in the library with a candlestick. That is not your job. Your job is to say there was a murder here, somebody go and figure it out, right? And then everybody else gets to play the game of figuring that out. It's not even my job to say exactly when it happened and who did it. It's my job to say, hey, this is not normal. We need more people to look into this. Let's get the DA involved. Let's get the police involved. Let's get CPS involved. Let's, however high we need to take this, we get this involved. And then each of us all work together in our different roles to collectively figure that out and make sure that that child has a safe spot around them. So CSEC, commercial sexual exploitation of children, is a component of human trafficking, okay? Human trafficking is something that we all need to be aware of because it absolutely happens in our area. It is happening. We are missing it. We just don't know it, we don't see it, okay? So, but first we have to know what it is before we can start to identify it, okay? And so human trafficking of adults has 3 components, okay? Action, means, and purpose. The action is recruiting, transporting, or harboring. It is not kidnapping or taking across state lines. It can happen within inside of somebody's own home, okay? And then the means is they're using force or fraud or coercion for the purpose of labor trafficking or sex trafficking. Not all sex workers are trafficked, okay? Not all runaway teens are trafficked, but there are certain groups that are at high risk for it, okay? And in kids or child sexual exploitation of children, we do not have to have the means. You do not have to have force, fraud, or coercion. You just have to have an adult or another person recruiting, transporting, or harboring a child for the purpose of labor or sex trafficking, okay? The human trafficking industry is the 2nd largest criminal industry in the world. And if you think about it, a human that can be reused and reused and reused is like an infinite resource versus drugs you have to smuggle across from Mexico and sell, and then they're gone again, and you have to do it over and over and over and over again. Whereas a human being that you are using for your own criminal commercial purpose is there and is a constantly renewable resource. It's estimated that there are 40 million victims worldwide, and it's estimated that only about 1% of victims have been identified. We don't have a great estimate. We don't have a great idea of how often this is happening or even where it's happening. This is a 1888 number that I'm going to give you here in just a second that I want you guys to all have and know about. But this is the National Human Trafficking Hotline's call log, and so it kind of shows you where these calls are being made. It doesn't tell us exactly how often or who and things like that, but it tells you the hotspots. Now that may reflect that we're pretty good in California and New York and along the East Coast on educating, or it may reflect that that's where most of the population is, or it may reflect that this is where most of the human trafficking is. But can you guys see the I-5 along there? That's us, right? We're at the top of that I-5 there, not the top, but we're on that I-5. We are a major transport point for that, for trucks that are going up and back and forth between Sacramento and LA. And so this is us. This is our area. This is happening in Sacramento for sure. And it is impacting the kids of our community. If we look at the age of entry, we have a clear spike right there at that late teenager, mid-teenagerhood time period for both labor and sex trafficking. Sex, 19 is the average age, labor at 23. When you talk to these kids one-on-one and actually interview them, a lot of them say that their actual first point of contact for sexual abuse was average age of like 9 to 14, depending on where you look at it. So this is happening. The grooming process starts at a much earlier process, or much earlier time period. But in California, we have that magical 18-year-old age where when you're 17.999, it is highly illegal and highly concerning. And then when you turn 18, things change, the rules change, and so that's why they're smart. They're onto that and start the grooming process before 18, engage around 18, just because of the rules, the implications, the consequences are so drastically different before and after. Labor trafficking. This is really interesting, and we are still learning more and more about this, but it is unfortunately a real thing in the United States. A study just came out where they screened in the emergency department, and they actually found more cases of labor trafficking when we're actually asking for it than sex trafficking, even though sex trafficking makes a much bigger splash on the news and something that we're all more aware of. There has been a paradigm shift inside of the United States from prosecution to protection, because we recognize the power dynamics and the way that these people are recruited, harbored, coerced, frauded, all of these things, that these are not choices that are being made. Even if they think that that is their choice, there are things that are not their choices. And so we've moved away from prosecution to protection and see them now as victims. So there's been a major shift inside of that. A lot of these kids have tattoos. Tattoos are not diagnostic, but anytime you see a tattoo that has, property of, or in the stable of, or some weird tattoo, that can be one of your signs that are there. These victims of human trafficking and CSEC, they're not your easy patients, right? Like the tools, the resources that help them survive on the streets are not ones that help them in our setting, right? Like you guys know these patients. These are challenging patients. The tools that help them to be able to stay alive out there do not make them for easy patients, right? Like they're the ones that we're gonna have problems with, that aren't going to want to listen, aren't going to want to stay, aren't going to want to sit still. They need to be out there. They need to get back in touch with somebody or they're going to get in trouble. The consequences of leaving AMA from one of us is much less than the consequence of not checking in with that pimp or letting them know, or selling those drugs, or getting themselves back out there, making more money. Those consequences are much larger. So they have to make decisions, and we don't win the vast majority of time. So we need to use trauma-informed care. Trauma-informed care means that I recognize that I have biases and that I might have trauma in my past, maybe even trauma that we've experienced with those types of patients, that color the way that I interact with you and what I expect from you. And it also recognizes that our patients have trauma or experiences in their past that change the way that they see us, right? Your uniform looks a lot like a police uniform, right? That may trigger certain thoughts and feelings within inside of them in the way that they trust and the way that they interact with you. Or they may have had an interaction in the hospital. Like for us, they may have been in that resuscitation bay with somebody else that they loved that died, right? And that's triggering to them to be in that, understandably, right? I have adults that have a hard time bringing other kids in because somebody died inside of that hospital that's there. It triggers them to feel emotions, and then sometimes, a lot of times, they don't even recognize it, or I don't even recognize my own biases. And so I am treating them and interacting with them, and they're treating me and interacting with me with biases, with trauma in our past, with experiences that change the way that we interact, and we don't even realize it. And so recognizing that is first, being understanding, being quiet, calm, getting down on their level as much as you can in a safe spot, like being able to just give them space and recognize what is going on is a trauma-informed approach to these kids, to these people that are struggling with it. Does anybody have any tips or any thoughts on that piece of it? I know this can be really challenging cases. Okay. So when we ask about human trafficking in a child, if you reasonably suspect somebody is being trafficked, you can report. In an adult, you don't have to report in California unless they want you to report. And the questions that I ask, everybody has a slightly different process, and none of them have been validated in the paramedic field and out in the field. But the questions that I ask are kind of what you guys do, where you set the scene by saying, like, I ask all of my patients that are here. So I'll say, I ask all of my kids that come in with STIs, or all of my kids that come in with injuries, these questions. I usually start outside of the child instead of bringing it to them directly to the teenager. And I'll say, sometimes kids are in a position where they have to exchange sex for food, drugs, money, shelter, or other favors. Do you know somebody who's ever had to do that? If they say yes, they're at super high risk themselves. If they say no, then I say, have you ever had to exchange sex for food, money, drugs, shelter, or other favors? And then I use that as a way to be able to ask them that question. I'm pretty point blank. Other people ask more general questions, and I think that that's okay too. That is my, oh shoot, where's my, there it is, okay. then we are just providing a open door for these kids. We're just for human trafficking, specifically for adults, we're just trying to provide a safe spot, because it takes several encounters with the medical community, with other people, to be able to feel safe enough to ask for help. And so you're just trying to open that door. And so I'll say, if you ever find yourself in that spot, or if you ever know somebody who has, consider giving them this phone number. And this phone number is the National Human Trafficking Hotline. No matter where that person is at, that phone line can figure out where they're at, and they know all of the resources, right? Like we've got My Sister's House, we've got IRC, we've got resources in Sacramento. But if you give them each of those different phone numbers, they're going to have a hard time figuring out who has what resources, whereas this hotline can actually connect them with the right resource, with the right people in real time where they're at. So you could be, and they often are, along that I-5, you could be in Fresno, or you could be in Sacramento, or you can be in San Diego, and be able to get the resources that you need right there. And it's specifically set up this way so that it can be memorized and not written down, because you don't really want to, we don't discharge a patient from the hospital with a chief complaint of like human trafficking. We think you're a victim of human trafficking, call this hotline, right? They could get in real trouble for having paperwork that's like that. So this phone number is meant to be memorized, 888-373-7888. This is a QR code for a podcast that we did that's called Sold for a Chrysler 300, and tells the story of a patient that came through UC Davis who was identified as a victim of human trafficking, and was able to get out and create a new life for her. But she had severe infections throughout her whole body that required multiple surgeries, and that's why she was sent over to our hospital. And it has the resources that are there if you want to look at it. This also is another, if you're interested in learning more and advocating with inside of public health, this is something that we in the medical community, a resource that we have is called healtrafficking.org. And you can see lots of resources there for everybody across the health continuum, and also you could be part of a listserv if you're interested. So what do I do now? What if you identify somebody who may be a victim of abuse, human trafficking? What are you guys going to do? If you can at all, get them to us. I think that's really an important piece of that, because we can take a little bit more time, the luxury of time that you do not have, to dig in, get different shovels to dig through the situation that's there. Yeah, and then documentation is key. What are some of the components that you guys document? Like, what do you document? I mean, I think more details is better, because these scene calls all start to run together, and for me, the cases all run together. So if I don't write it down, it didn't happen, you know, because I shouldn't go up to court and say like, oh yeah, they had cereal all over the floor, if I didn't write down cereal all over the floor, you know. And you guys can be called to court, and I go to court and tell them what you guys wrote down that's there. Like, I review all of your reports when they come in and we're concerned for child abuse. Because it drastically changes what we're doing. You guys are our eyes, you are our ears, you're our noses. You're seeing things and experiencing things that we are not. And those discrepancies between, is this a public confirmable accident? That's on you guys to document and to tell us, you know. Did you pick them up at Walmart and outside where the carts are and everybody agreed with that? Then yeah, this is a public confirmable accident, you know. And we don't need to call CPS no matter what the injury looks like, you know. So you guys documenting where you were, what were the circumstances were, do really drastically change things for us. We had a case, I think, Joe, before you came on to CDRT, where there was a kid that came in with seizures and ended up having blood. It was a really super complicated case, and it wasn't until we were in a multidisciplinary setting and we pulled up the medic run sheet that we realized that mom was dry and there was no towels around, and even though mom had said she'd been in the shower with the kid, and like it was just like a totally different circumstance. And I've had cases where the parents said that, oh, something happened in the shower or in the bathtub, and you guys get there and like there is no bathtub, you know? And so like what you guys describe and see is a really important piece of like matching what we're doing. Does this mechanism match the injuries that we're seeing here? And then also you have that opportunity to like see the sketchy stuff that's going on there. You know, we all build up protective barriers around our kids, and sometimes there's gaps in that, and you guys can identify those. Yeah.
Yeah, I remember when Metro Fire first switched to the electronic PCR platform on Imagetrend, I thought, oh my gosh, look how long these narratives are. They're long, and then you get to reading what you are actually documenting and going, oh, I totally get this patient scene. You're doing a good job of telling us. It's so important to tell us about, and even just saying, I walked into a really dirty, unkempt apartment
Yeah.
and found the patient here short of breath, or I found the patient injured. It's like, I'm getting a picture, and some people say, oh, that scene stuff's not important, and it is so important.
Yeah.
Because it really does paint a picture for us. Hey, here's a patient who may be a victim of non-accidental trauma, but maybe there's change in the paradigm, but maybe a patient who's in a setting that they just need additional resources to survive and to recover. So the narrative pictures that we see in the long text of the narrative notes, and I realize that that's not data, it's just a picture that you're painting, but sometimes that picture makes all that other data makes more sense for us.
Or there's pieces that we can help and components that we can change on. And that is why we report, right? We report to protect that victim. We report to protect the other kids that are inside of that circle also. And we can help that abuser, that mom that said, now I'm drug free and I have a home and I have my kid in my home. And I was not on that pathway 6 months ago when CPS first made contact with me. Now that success story is not always there, but that is CPS's purpose, is to provide that pathway for these families. That can be frustrating for me. I am not going to lie. There is a lot of times when I'm like, you burned up your parent card in my book. So there is that conflict that's there. But that is CPS's purpose, is to provide a pathway so that that child is in a protected environment. And first and foremost, if it can be with a parent, they do. So you can affect change by making these reports. Do you guys, let's talk about reporting here really quickly. What do you guys see as what do you do when you report? Do you just say like, hey, doc, I saw X, Y, and Z, and then pass it off? Do you feel comfortable with that? Do you take time out, go offline and call CPS yourselves, or like what have you guys done? Yeah.
So we'll pass it on to the doctor, but
yeah.
I think that's the main thing that I wanted to get out today.
Yes.
That's what we feel like is we're done.
Yeah.
But it's not. We need to go back to the station, do the CPS report,
Yeah.
and then encourage them. We then send it to our EMS folder, and then we follow that up.
Brilliant, Joe. Yeah. And so much gets lost with that, because I go back and see your notes, but I guarantee you that most of the people are not reading your notes with the fine-tooth comb that I am. I copy and paste your notes into my notes, so when I report it's in there, but we're one hospital in the area, and we don't get called on every single case. So if you have concerns, you need to report what you are seeing. You are a mandated reporter. In California, that means that you reasonably suspect, in your professional capacity, not driving down the street, you're not a mandated reporter for somebody that you randomly see on your street. You want to do what's right as a human being, but the rule is you reasonably suspect in your professional capacity that somebody is a victim of child abuse. And so again, you don't have to say it's Dr. Plum in the kitchen with a pipe. You just have to say, I saw X, Y, and Z. Be as objective as you can. This concerns me for ABC. And just be very clear, be very objective, and share your component that's there. CPS, the vast majority of cases, they don't actually end up doing anything about. But when it comes from us along the healthcare continuum, they do take those rise to a different level. And it might just be them going to being like, hey, let's walk in through the house. Do you have food? Do you need better food vouchers? Do you need another bed that's there? Your housing is not meeting the code standards for X, Y, and Z. So let's make sure that you're in a house that does meet code standards. You know, there are resources that they're part of our safety net as a community, but they don't know where to go if we don't tell them where to go. So not all CPS events are negative. Now, it still doesn't feel good to be that family member, and so we want to be as objective as we can. We want to reduce bias as much as we can, but it's better to overcall than to undercall if you see something that you're objectively concerned. And you guys see the whole curve, the whole bell curve. So if it's over there on that side of the bell curve, the very unusual, that means something because you guys see so much stuff that's out there. Joe, other thoughts? Anything else you want to add?
I appreciate that you came out and spread a little awareness here, but I think the main thing is that we need to report. The form is not lengthy, it's very quick, and
Yeah.
we just need to run number and then we talk to them.
Yeah.
With the ones that are really clearly like an environmental or physical abuse, we also have the ability with our EPCRs to take pictures with the iPads. So if there's like a really strange environment,
Cool.
I've only had that like maybe once or twice.
Yeah.
As a paramedic, we have the ability to take a picture with our iPad and
Yeah.
then attach it to the EPCR.
Yeah, that is like super money. From my standpoint, that would be really key. And that would be key for CPS as well, to be able to see that type of documentation. You know, that picture is worth 1,000 words, you know. Can save yourself some time. I use picture documentation in my child abuse stuff all the time because it's much easier to take a picture and be able to see it. I still have to write it down in case something happens to the picture, and then you just never know. But that's really important. And then just as a personal plea, if you're doing chest compressions on an infant, if you can write down what type of chest compressions you're doing, it is so helpful to me, because then these, like we talked about with these abusive head trauma kiddos, their RAS system is affected, and so they stop breathing. They often need chest compressions, and then they come in with rib fractures, and then in court we're trying to figure out, did we cause those, or did the parents cause that with that shaking, that holding around the chest that you were referring to. So just as a personal plea, if you have time, please document what type of compressions you're doing. That's super helpful to us. Dave, you have thoughts? Okay, we want to treat these families equitably. While it is easy to be angry, to know that there's something wrong in this, and to feel inequity for these children, we need to objectively report these findings. We need to be as objective as we possibly can, stuff those feelings, and then address them later with your colleagues, because the vast majority of times it is not the perpetrator that's there at bedside, that's there with that child. They don't know, and by creating a wall or a barrier, they may lawyer up. They may not feel comfortable talking to me. They may not feel comfortable talking to CPS or law enforcement later, depending on how we treat them at those beginning times. So while we're still figuring things out, it's particularly important to treat everybody equitably and kindly. And I always say that we get more flies with honey. And so sometimes I have to prep the nurse before I walk into the room. I'm like, I'm going to be really nice to this family. I know you're really pissed at them. I need you to know that I am doing this very intentionally for these reasons, and bear with me on this. But then work through this frustration, work through this with your colleagues, and make sure that you give space for those frustrations afterwards and during. I had a nurse in residency that would come out of her room with abuse, and we'd walk out together, and she'd be like, all right, that's another 2 miles on the treadmill at home later on, because it's frustrating. And so you have to have a healthy outlet to deal with those emotions that are there. So I want you guys to know that what you're doing does matter. You can make a difference in these kids' lives. What you're doing by documenting, by reporting, by sharing, by taking pictures, by being aware of these, by educating the hairs on the back of your neck does make a difference in these kids' lives. And I appreciate what you do, because I know that it is not easy. And we as a community, as a society, appreciate it as well. So thank you guys. And that's it.
Thank you.